This short lecture provides an overview of the benefits and challenges of economic evaluations for nutrition interventions using findings from multiple studies. This lecture describes how a rich qualitative understanding of time allocation and household costs and context is essential for estimating costs that are useful for program evaluations. This lecture was delivered at Nutrition 2020 Live Online on June 3, 2020.
Today, I'll be discussing benefits and challenges of economic analysis for nutrition interventions, a review of findings. So, some background first. Why should the nutrition community care about economic analysis, specifically cost-effectiveness analysis? While the answer these days may be more obvious, back in 2012, Action Against Hunger was one of the first NGOs that really started working on cost-effectiveness analysis for nutrition. And they had two primary reasons for this interest. First was on the research side. They wanted to be involved in building the evidence base on cost-effectiveness of what they saw as some strategic nutrition programs. There was also a donor interest. Their donors had recently begun asking them about the value for money of their humanitarian field programs, and they didn't really know how to respond to these requests. My experience in the nutrition community is that economic analysis and cost-effectiveness analysis are often met with a sense of nervousness, because sometimes nutrition doesn't look cost-effective relative to other interventions, other sectors. And I'm here to tell you today that economic analysis is actually quite nuanced and context dependent. It's not quite as cut and dry as it sometimes seems. So I'll be discussing this in the context of benefits and challenges of economic analysis for nutrition interventions using findings from multiple studies. And I'll be discussing many studies quickly and won't be able to provide all of the details, but all results are published and references provided. And just a couple of quick notes on the kinds of programs that I'll be discussing. First, community health workers, or CHWs, treating acute malnutrition versus more facility-based strategies such as CMAM are some of the findings that I'll be discussing, as well as cash and voucher transfers in humanitarian settings. So a quick outline of regarding the benefits and challenges that I'll be discussing. First, building the evidence base, benefits and challenges on this. Second, understanding household costs, benefits and challenges around this. And finally, the importance of context for cost and cost effectiveness analysis. And when I refer to benefits in this context, I really mean advantages rather than economic benefits in a specific sense. So first, building the evidence base. Building the evidence base on cost and cost effectiveness of nutrition interventions. What this means is that we have an opportunity to track costs in similar programs across different contexts. And in this way, we can see what resources we use, what are the trends, so that we can forecast and budget appropriately. All of this enables us to assess affordability of programs in different contexts, to start getting a sense of what works and what doesn't, what's efficient and what's not. And we can use this rich information on costs so that we can do things like advocate to ministries of finance when looking to have local governments help support programs and co-fund along with international donors. Taking the time to look more closely at costs gives us opportunities, for example, to learn from stakeholders who have good insights into program costs, such as implementing staff who have a very good idea many times of where program resources might be used more efficiently, as well as program beneficiaries who spend time and money in our programs and have opportunity costs for this time. All of this can lead us to understand the economic consequences of how we implement, and to think what changes could be made to improve efficiency, including for households participating in our programs. An example of the benefits that can come from assessing program costs comes from an analysis of a cash transfer program to prevent undernutrition in Burkina Faso. The intervention area was large and sparsely populated, And we also had security concerns. And some of the precautions taken with distribution of cash in this setting caused delays in our distributions. In our analysis, we found several cost drivers, including high transport costs. And this was for a couple of reasons. Both the private partner involved in distributing the cash brought in armored cars to distribute to remote villages, and because due to the intervention area being so spread out, we had our program staff visiting their villages every month to discreetly remind them about the upcoming distribution. And all of this back and forth travel caused high transportation. Because of the distribution delays, we also had long wait times in remote villages, a day and longer, especially at the beginning of the program. We conducted a sensitivity analysis, and because we had measured household costs and could assign a monetary value to the time spent by beneficiaries in waiting for distributions, we found that larger efficiency gains actually came from reducing beneficiary wait times compared to potential reductions in transport costs. So this provides a good example of the insights we can gain when looking closely at costs, especially at household costs. And it also shows how this information can feed into program design. There are some challenges around building the evidence base. Primarily, there is a methodological challenge, which is the limitation of cost effectiveness analysis, which is that total costs of our program can be divided by one outcome at a time to create a cost effectiveness ratio. So that one outcome had better be very strategically chosen, or one that we feel really reflects the performance of our program. And when looking at nutrition outcomes, we can find a challenge for multi-sectoral nutrition and nutrition-sensitive programs. And this is because there's a longer impact pathway in between our intervention and the nutrition outcomes, and a smaller effect compared with nutrition-specific programs on these outcomes. So these programs can appear to be less cost-effective per nutrition outcome. However, multi-sectoral and nutrition-sensitive programs often produce many more benefits than just the nutrition outcome alone, which can't always be included in economic analysis, and we'll discuss this more later. So we may find, and I found this more than once, that stakeholders may refuse to publish unfavorable results of a cost-effectiveness analysis. And I would just like to suggest that we need to be braver about building the evidence base for economic analysis in nutrition. Because what seems expensive now, with limited evidence, may actually be standard in the future. And not all of our interventions will be as cost-effective as vitamin A distribution, for example, but we may find that we have many more benefits in nutrition-sensitive programs than in strictly nutrition-specific programs. Another challenge in building the evidence base is that decisions on what is considered cost-effective are not necessarily static, and decision rules can change. For example, the methods were recently changed that are used to calculate disability-adjusted life years, or DALYs, a measure used in cost-utility analyses for nutrition. And they dropped age weighting and discounting, and this effectively increases estimates of DALYs averted. We did an analysis with colleagues and found that compared to historical estimates, the new methods increased DALYs averted for acute malnutrition and CMAM programs to 2 to 3 times higher than historical estimates. So when you divide the same cost by a higher number of DALYs, more programs are actually looking cost effective with our current decision rules. And so these metrics and benchmarks can change, and our decision rules are likely to have to change over time to reflect this. One example of a program that did not look cost effective according to cutoffs was community vegetable gardens for people living with HIV in Zimbabwe. In summary, providing gardens to people living with HIV cost around $13,000 in 2020 US dollars per household with food consumption score raised to an adequate level, and cost around $19,000 per household with household dietary diversity score raised to the upper tertile. These were the outcome measures used in this study. The gardens did seem to provide a valuable asset to communities because more than 80% of the gardens were still functioning more than 1 year after the program had ended. In community discussions, households cited multiple benefits, including increased income from the gardens, which was actually included as a negative cost in our analysis, but also multiple intangible benefits, which could not be monetized for economic analysis, including increased strength, reduced isolation and anxiety, community cohesion, and reduced stigma against people living with HIV. The conclusion of the analysis is in blue at the bottom. Due to the high costs relative to Zimbabwe's per capita GDP, this program wasn't likely to be affordable in government services. However, given the multiple benefits, these kinds of programs hold a lot of potential to improve quality of life for people living with HIV. This particular program might have been inefficiently implemented, and it will be interesting to see as we build the evidence base and get more data points if this kind of intervention could have better economic value in other settings. As we continue to build the evidence base, we should keep in mind the key role that households' costs play in understanding economic implications of nutrition interventions. When we talk about measuring household costs, this means asking program beneficiaries about their time and cost in participating in a program. This can help us understand financial barriers to program access and utilization that households face. In particular, we can get interesting information comparing the burden of time and cost that different implementation modalities require of households. For example, we have data from 3 settings on household costs involved in having community health workers provide treatment for acute malnutrition rather than getting care from facilities such as CMAM facilities. In Pakistan, facility care costs twice the money of community health worker care. In Mali, facility care costs 3 times the money and twice the time of community health worker care. And in Bangladesh, hospital-based care costs 6 times that of community health worker care. This provides interesting information that highlights what kinds of program modalities may be most useful for communities. We can also use household costs to see how implementation costs are shifted to beneficiaries at times. Here's an example from a cash and voucher program in Pakistan. The implementing organization made a decision to distribute cash centrally at a district capital to reduce operational costs relative to distributing in villages. Only 15% of cash beneficiaries received their transfer in their own village, compared to voucher beneficiaries who could redeem their benefit closer to home. Traveling to the district capital to collect cash took up to 1 day of travel due to bus schedules. As you can see in the table, for the 3 study arms, that was single cash, double cash, and food vouchers, we have the average monthly household cost for the program, the monthly transfer value given by the program, and the cost to household as a percent of the transfer value. And you can see in the bottom row that the arm receiving the least cash had a very high percent of their transfer taken up by transport costs at 20% relative to the voucher arm at 5%. This has implications for program design. We can either aim to distribute cash locally or provide a transport top-up to prevent this kind of erosion of benefits in the future. I hope I've demonstrated that household costs are useful to understand. It does take time and resources to get good quality data, however. We often default to wanting to use surveys to collect data from households, but questions on time, cost, and income require very good enumerator training, as well as time to explain the questions well to beneficiaries. And survey data can be biased if questions are unclear and answers are not well formulated. From my experience, using qualitative approaches can make it easier to ensure that questions on these concepts are better understood. Of course, qualitative approaches can take more time compared to surveys, and it can be difficult to get representative data for large populations using qualitative data. Finally, there are some contexts in which household costs may not be relevant to collect, but they should be considered in planning, and I think researchers should need to opt out rather than opt in to collecting this data, given how useful the information can be in cost analyses. Just as the importance of household costs can vary by program context, there are many other aspects of cost and cost effectiveness analysis that can be influenced by context-dependent factors. Cost estimates and calculation methods can vary across studies for many different reasons. I think we all know that different countries have different salary structures, which makes personnel costs vary widely across geographic areas. There are also program characteristics, the way certain programs are implemented, and methodological reasons why costs of similar programs can vary between studies in the literature. We need to be careful comparing across contexts, as these comparisons can be misleading. Obviously, we need to be careful in comparing across different contexts in terms of geography, disease burden, etc. But I want to focus on some more subtle contextual factors in areas where context matters, even in comparisons within the same country. Coverage can affect program effectiveness and hence cost effectiveness, as we saw in a program in Mali. Here we had community health workers treating acute malnutrition compared to facility-based CMAM. There were some problems enrolling children in the CMAM arm, and this arm in the end had just 1/3 of the beneficiaries of the community health worker arm. And this was due to a couple of reasons, possibly a lack of community sensitization in the CMAM arm, which was an ongoing program, as well as potential researcher bias favoring this arm as the new and interesting intervention modality using community health workers. We correct for this in a scenario analysis, assuming the same number of children in both arms. And when we did this, our conclusions changed, and the CMAM program became more cost-effective than the community health worker arm, as seen in the bottom row. As you can see, the cost per child recovered, which was our main outcome in the analysis, in the community health worker arm, was around $250, while the CMAM arm base case amount was $500, double the cost. But assuming the same coverage in the last column, CMAM cost closer to $200 per child recovered and was the most cost-effective option. So in this setting, cost effectiveness really depended on coverage. Here in Pakistan, we had a similar program with community health workers treating acute malnutrition. This time, there were some political challenges that influenced the context. The two programs, community health workers and CMAM, had similar costs, as you can see in the table, but CMAM looked more effective for several reasons. Community health workers had poor quality of care in this setting, which led to lower effectiveness in that arm. This was because many reasons. First, they were overburdened. There was a polio campaign at the same time as the study, and they didn't get a salary top-up, as they usually did in adding a new task to their workload. So in this case, treating acute malnutrition did not come with a salary top-up, and this led to low motivation. There were also unclear ways of working between the NGO conducting the study and the government, since there was a change in government midway through the study. And finally, community health worker supervisors, who were Ministry of Health staff, did not participate in the first half of the project. So you can imagine if your supervisor isn't supervising you on a particular task, you're not going to focus on that task and perform it with particularly good quality. In the end, there was uncertainty as to which program was more cost-effective, as you can see in the last row in the table. CMAM was on average slightly more cost-effective in this setting. So in conclusion, a few takeaway points from this presentation. First, economic analysis can provide important insights into resource use in nutrition, and this information can help improve program design in many cases. Despite our nervousness on how cost-effective nutrition might be relative to other programs or sectors, we need to be braver about building the evidence base. Second, household costs are particularly important to understand and should be considered in study planning. However, it should be known that collecting these data requires resources and dedicated effort. And finally, we should be cautious when taking cost and cost-effectiveness results out of context. keep the nuances in mind that affect the cost data, especially as we grow the evidence base and have just a few data points to start out.